The United States is the country of innovation and the country of do new things. And the rest of the world imitates the United States. What I'm going to present is what is happening in many developing countries, that they are already, look what is going to happen here, but in addition to that, they have received the advocacy of many of our colleagues that have going to do the developing countries bringing the solution, but without bringing all the care that the United States has had for taking those decisions. What I'm trying to say here is that in developing countries are only the contents that are being transferred, but not anything related to the basic studies, what were the origin of those decisions. And this slide for this group probably is not needed, but I'm going to mention anyway. Fortified foods do not have any biological impact. The fortified foods are no more than the vehicles of the solution, as we have seen in the first two slides. The impact is due to the amount of the food that is being consumed multiplied by the content of the nutrient that we have added. That is going to give us the additional intake. But that is not sufficient. That nutrient needs to be bioavailable, and that nutrient in some cases need to be bioconverted, and that could be the case of folic acid. Folic acid is very easily bioavailable, but for bioconverted into folate, it requires B2 and niacin and other things. Once we have that inside the organism, the additional intake needs to be added to the basal intake. If the basal intake is sufficient, we are not going to expect any type of impact. If the additional intake is not sufficient, we are not going to expect any type of impact. What is making us the solution is the total intake. Once we have that, then we can expect to see some changes. First in biomarkers of intake, then in metabolic biomarkers, then in clinical signs, and finally in functional signs. I have seen in many countries by the simple introduction of iron into certain foods, then the studies are oriented to see reduction of anemia without thinking and considering all the different factors that are really making the prevalence of anemia. And that is what is happening in developing countries. I worked in the Dominican Republic 3 years ago, and we wanted to find a vehicle that we can fortify for supplying those nutrients that were insufficient in the diet of that country. And you can see in this graph, the blue part of the graph, each of us, this is the distribution and the intakes of maize flour. This is cumulative distributions. Less than 15%, that means that 85% of the population is not eating maize flour, but only 15% here. And this is the distribution of consumption of the intake of maize flour. That was very little for around 80 grams per day. A difference of the rest of Central America, fortifying maize flour in the Dominican Republic is not going to work. Despite some were thinking that because this belongs to the same group of communities, they should fortify maize flour. The purple squares is the distribution and the fortification of wheat flour. That is very well distributed, although the intakes in the median is around 50 grams per day, and the ones who are eating the most around 100 grams per day. That is the half of the intake of the US. It's already been fortified in the Dominican Republic following the Central American regulation, that the Central American regulation is an imitation of the US in part. We have then studied here the intake of rice. This is a rice-eating country. And if we fortify rice, that will be very highly impacting because we can put some amounts of any nutrient there, and it will be, the consumption of those will be high. If we combine wheat flour with maize flour, we have the green triangles. That will be even better. That means the combination of the two, we can cover certain proportion of the population that for some reason is not eating rice, even in the Dominican Republic. The difference between those who have low consumption of these two foods and the ones who consume a lot is still there. That is one of the characteristics of mass fortification. That means some are going to benefit a lot, while others are going to be benefit not so high. Then the WHO, a few years ago, came to some type of guidelines for the world. And in that meeting, it was decided that the fortification formula should be based in the average food intake and in the per capita one. And we have here different per capita average of intake in the countries, and they recommended, these are the fortification levels for each one of these fortification intake patterns. But the problem is that that is based in the average intake. It's not in the distribution in the population. Despite of that, the WHO guidelines has a footnote that says these estimates are considered only when wheat flour is being fortified in the country. And it's only the only source that you could supply those nutrients. If other mass fortification programs with other food vehicles are implemented effectively, that levels of the nutrient that we are putting here, they should come down. No one reads the footnote. And what is happening is that the advisors from outside comes to the countries, look for the intake, the average intake of the country, and they decided that this is the formula the country should have. And if the country has a 75 grams per day intake of flour, this should be the contents of these nutrients, which in the case of the Dominican Republic, they should imitate this. These contents are not feasible and technically and economically possible in the country. Those are very high, and it's going to make the foods very expensive. But those little things are not being transferred in many cases. But now let's move to some examples of programs. Despite that we should follow the biomarkers, we still need to measure some intakes, because we need to make the link between how much is the change of the intake and related, which is the size of the solution, or the size of the impact. This is the case of Jordan, that is fortifying wheat flour with many nutrients, but we are only report two of these, iron and vitamin A. It was expected, according with regulation, that the amount of additional iron should be 34 milligrams per kilogram and vitamin A 1.5 milligrams per kilogram. The real addition was not that, it was 27 and 1.2, but not a matter, it's something new there. If we know the consumption of wheat flour in the country, we can estimate the additional intake, and with the additional intake, that transform in the percentage of estimated average requirement. In the case of children, it's 52% of iron is in addition of as ERR, in the women 20. Vitamin A is in the other way around. The contribution in the diet of the women will be higher. Then, without doing the experiment, what we are expecting from this type of intervention? And the results are here. When the analysis of the national survey from 2002 is compared with the 2010, the iron deficiency in the children was reduced from 10 to 4.8%. The iron deficiency anemia from 26 to 14%. But if you see the case of women, nothing happened. But it is easy to explain. The contribution through flour was much higher in children than in women. And in the case of women, in addition, that they are not receiving an additional amount that is high enough, they are having a lot of consumption of tea, which means that also the bioavailability of iron could be lower. Is this program a success or a failure? Well, it's a successful because it's contributing in the additional intake of those nutrients. But we cannot expect that it works simple because the flour is consumed, because the iron in this case is not sufficient. We need to do something else in the case of the women. In the case of serum retinol, it did not change in the children. And well, we can say that this additional amount was not high enough, or something else happened. Serum retinol is affected by infections, and probably something here that we are not really seeing why the biomarker is not really expressing the additional intake. In the case of the women, we don't have the baseline, but we only have the final system here, the final data is around 5% below 0.7 nanomoles per liter. That means that that population probably is not vitamin A deficient, but something else could be done. Keep in mind this 5% in number. I'm going to compare that result with the data from Guatemala. Now, let's go back to the folic acid story. This is in Chile. Chile has the twice of amount the intake of wheat flour of the US, around 200 grams a day. It's a very high intake. Despite of that, instead of adopting 1.4 milligrams per kilogram, that was the adoption by the United States and Canada, Chile was receiving the advice to put 2, because 2 multiplied by 200 is 400. When that advice was done, was considering wheat flour as exactly the same work as a supplement. The women in Chile are already receiving 400 micrograms of folic acid per day. That is like the supplement. And the women that are eating less wheat flour in Chile could be 100 grams of wheat flour, which means that in the minimum case in Chile, the women are having 200 micrograms of folic acid per day, which is the average in the US. This is what happened in the reduction of neural tube defects, as we can expect. With this high intake of folic acid, this reduction was expected. And that is a very successful program in the system. It has remained in 8 cases per 10,000, which means that other reasons are there. It's not anymore associated to the deficiency of folate. But is this program safe and efficacious? The case of folic acid is interesting because there is a linear correlation between intake and the contents and the concentration of folate in the serum. These green columns are the distribution of folate in the serum before wheat flour fortification. Now we have the yellow ones. This was a complete movement and very high values of folate in the serum. The United States is in the middle of this thing. It's here in this part. But the impact is the same. That means in the United States was needed only between 100 to 200 micrograms of folic acid. In Chile, they are using 400 for the same impact. In South Africa, it's even less. That means that it is true that folic acid reduces neural tube defects, but it is safe. We don't know. You can see these values here, and these are the women. The males are eating at least 30% more wheat flour than the women. It means that in Chile, this experiment is already taking place. The problem is that because the good impact of having reduced neural tube defects, no one has want to have the chance to reduce from 2 to 1. Because if something of the neural tube defects is increasing, they could be attacked and saying this is the reason of these things appear again. That is what we should be careful. Like Christine was saying, we need to start moderate and conservative. We cannot start with very aggressive interventions because once we have that, it's very difficult to come back. The second question is this efficient? Do we really need this huge amount of folic acid for having that impact? Probably not, but because it was done in this way, we will never know that this is the case. In Guatemala, which is the country of my origin, vitamin A is added to sugar since 1974. And sugar is something that the people think we should avoid the consumption. But then it is still important or not to continue using sugar as a vehicle in Central America. The poor communities in Central America, there is not any other food produced by the industry that reaches the poor. And no matter what we are saying, reduce the consumption of sugar, they are going to continue eating. If that's the case, why don't we continue using the sugar as a vehicle without promoting the increase in the consumption? What we did is trying to see the density of vitamin A in the diet, not through food intake surveys. We use economical household surveys, the amount of foods that the people is purchasing at the household level, and then we can estimate more or less which is the contribution in nutrients of those foods that are being purchased. In this case, what I'm showing here is the density in micrograms of vitamin A total, retinol, and beta-carotene per 1,000 kilocalories. This red line is the distribution of the densities in the very poor countries, in poor families in the country. The green one are the poor families, and the blue one are the families who are not poor. It is clear that the diet of the not poor has a higher density of vitamin A, which is obviously supplying that vitamin A that they require. In order to interpret this information, we make here an EAR adjusted by the energy requirement. We divided the 400 micrograms that is required by the children divided by 1,700 kilocalories to get this number here. This is only relative, trying to interpret this. If this diet is consuming the amounts of energy that the kid requires, how much is going to contribute by the vitamin A intake of those children? It means here that 75% of children in the very poor families are not going to reach the intake of vitamin A. For the poor families, 50, and for the non-poor families, 25. It confirms that vitamin A in sugar is still required in the country. There is no way that they are going to reach the requirements. This is the same graph, but we also calculated accordingly with the density of retinol. And you can see, in this case, we put the upper tolerable level, which is very well above. The diet in the country contains some retinol, but it's very far. Most of the vitamin A is coming from plant sources. That means that it's required and is far away from retinol. Vitamin A is added into sugar, and the annual average of vitamin A into the sugar is around 9 milligrams per kilogram from the last 5 years. And all sugar in the country is fortified, directly and also going into the foods. If we model that, now you can see, once we add the contribution of vitamin A into the diet, the density is going completely above. It's only a few of the families of the very poor sectors of the society probably are not reaching the vitamin A intake. All the others are above. And this is coming from retinol. The society changed completely from beta-carotene or provitamin A in plants to animal source. But in this case, you can see the two graphs. It's a very successful program. There is not any inadequacy, and there is very few which are reaching the UL. The problem is that, in addition to this, the government supplies vitamin A every 6 months, mega doses to the children. International agencies are coming to the countries and telling them they need to adopt micronutrient powders that contain vitamin A. Is those needed in this country? And probably not. Despite of that, the government is doing and following what these external advisors are coming to tell them. Now use biomarkers. Those were data, more or less, the density of the diet. But now we have also the numbers with biomarkers. These are blood samples coming from the highlands of the western parts of the country, near to Mexico, where are the poorest and where is 50% stunting. Despite of that, the children of Guatemala and the women are exactly the same as the women and children of the United States. In the case of the serum vitamin A. And we have here the distributions. For the children now, we have some of them, 36%, with serum levels of retinol between 1 to 1.4. Some women above 2, 15%. We are already pushing for very high intakes of vitamin A in the country. And even with this information, the country decides and is still supplying micronutrient powders with vitamin A. And that's, we have the data, they have the evidence, but the decisions are not taken based on that. And that is something that needs to be corrected. I put here below the means. The means in women are the same as the means in Guatemala, the same as the United States. But let me tell you, This is the poorest area of the country, and even in the presence of infections. And that will tell us really that the program is working, but we need to be careful, not going beyond that. Now going back to the design of Fortified programs. In the 70s, vitamin A was very popular, and there was a lot of experiments, and saying what is the efficacy of vitamin A in wheat flour and oil and sugar and salt and monosodium glutamate. And in the papers it says how is the impact of vitamin A, how monosodium glutamate that is fortified could reduce vitamin A deficiency. But if we transform all these experiments in the additional intake of vitamin A, all of them are more or less the same. They were supplying the same amounts of vitamin A, which in terms of percent of estimate average requirement is more or less the same. Then the conclusion and logical of this is in all the cases, all these experiments were efficacious. They improve the serum retinol, which was expected. But now let's ask a question. Have you seen salt with vitamin A, or have you seen monosodium glutamate with vitamin A? Despite these beautiful results, they never came and result in a program. Why is that? Because the scientists did not speak with the people going into the programs, and they went ahead doing the experiment without a need, because this efficacy trial, it was not needed to repeat in each case. What was needed is to consider if those foods that were considered to be fortified were fine or not as vehicles of the nutrient. If you can see, these are the different contents of vitamin A that we need to put in each one of these food vehicles to provide the similar amount of vitamin A. But that cost, if we transform this in cost, is from $3 to $1,362 per kilogram of the product. It's impossible, even looking at this, that the industry was going to accept to add this amount of vitamin A into the monosodium glutamate. It was not feasible. That will increase the price of the product by 27%, the price, which probably is twice the profit. We immediately think that this is not possible. Then why to do the experiment if from the beginning was already death for these systems? And this is based on price. Now based on the dilution factor, how much vitamin A needs to be added to these foods. In the case of salt, it's a dilution 1 to 1,000. In the case of monosodium glutamate, it's a dilution 1 to 40. In the case of wheat flour, it's 1 to 20,000. This comparison immediately tells you that when we are considering salt or monosodium glutamate as a source of vitamin A, if we would like to provide sufficient vitamin A, these two products will be supplements of vitamin A, which the excipient is salt or monosodium glutamate. That could not be working. Now, concluding my presentation, which is trying to solve another question. What happened in a society that is very diverse? Some people eating rice, some people eating wheat flour, some people with flour. This is Mexico. What we did here is trying to see in these columns the different quintiles of the socioeconomical group of the Mexican society accordingly with wheat flour intake. And you can see wheat flour is going up when the people is having more resources and more funds. The average intake in the country is this one, around 200 kilocalories per day. I put in this in kilocalories, not in amounts. It's around, if you divided this 200 by 4, it's around 50 grams of wheat flour per day. If we have now maize flour, which are these brown columns here, the situation is different, very highly consumed by the poor and much less by the rich, and this is the per capita. If we follow what WHO was saying, we are going to fortify these two things independently with very high amounts of the nutrients, which is not going to make sense. If we combine the two flours, you can see the green columns here, we reduce the difference in the different quintiles of the society, which means we are going to use lower contents of the nutrients, and our impact will be similar in all the groups. If we add to this the noodles and the pastas, we improve a little the system. The teaching of this is that we need to combine our vehicles. When we do that, then we reduce the difference among the different groups of the society, and we are going to put little less of the nutrients. That brings us to the concept of the fortifiable energy, that we need to start thinking that the supply of the nutrients should be in proportion to the energy that could be fortified in the diet. If we combine all of these things, we can really make a better decisions in the solution. I can explain to this later if there is questions. In summary, what I'm presenting here is in food fortification, as within any other nutrient supplying intervention, the impact is due to the amount and quality of the added micronutrients and not to the fortified food. That is a simple vehicle. However, coverage and programmatic feasibility depend on the nature of the fortification vehicle. That is what we need to study, the diet and the pattern. In most developing countries, fortification formulas have been selected through imitation and not for correcting estimate nutrient inadequacies or trying to prevent excessive intakes. As a fourth point, incorrectly formulated food fortification programs or that lack of monitoring and evaluation systems might already be providing excessive intakes. 5, the formulation based on fortifiable food energy may be an appropriate alternative to combine mass and market-driven or discretionary fortification. And for future directions, formulation of fortified foods should be reviewed to consider multiple food vehicles at the same time, as well as other interventions that are present, like supplementation. As there is hidden hunger, when we promote micronutrients, we say this hidden hunger. If we accept this, we need to accept that there is a possibility of hidden obesity. And therefore, it's important not only monitoring deficiencies, but also excesses. The approach of the fortifiable energy should be evaluated. We have already a model, and it was published in the Annals of the New York Academy of Science this month. 4, this is with vehicles that provide energy. What we are going to do with vehicles that do not provide energy, and therefore the energy intake and the consumption probably do not have too much control. And 5th, we should consider supplements as a complement of the current human diet, and therefore they should be subject to the similar rules that we are using for fortified foods. Thank you very much.